Welcome to Medicine Redefined, a podcast focusing on helping you reclaim ownership of your health. I'm Dr. Darsha.
And I'm Dr. Altamash Raja. We're your hosts, here to challenge conventional practices and uncover the stories behind pioneers shaping the future of medicine. Our conversations not only focus on the individual level to dissect common practices for health optimization, but also zoom out to enhance systemic change.
Join us as we look to break the status quo, move the needle forward, and put the health back in healthcare.
Our guest today is Dr. Jeremy Boyd. Dr. Boyd is the founder of Trifecta Therapeutics, a sports rehabilitation and performance practice with 3 locations in the southern New Jersey and greater Philadelphia area. He is both residency and fellowship trained and board certified in orthopedic and sports physical therapy. As a fellow of the American Academy of Orthopaedic Manual Physical Therapists, he demonstrates advanced skills in diagnosing and treating complex neuromusculoskeletal conditions, utilizing a comprehensive approach that integrates advanced manual therapy and psychological considerations. Dr. Boyd's expertise is trusted by elite athletes from the NFL, NBA, MLB, and the Olympics, and he has a particular interest and focus on ACL injuries and rehabilitation within his practice. On a personal note, I've known Jeremy for over 3 years, and I consider myself to be an extremely lucky individual who has known world-class physical therapists, one of whom was a prior guest, Dr. Dan Pope, and Jeremy Boyd is also in that class and a class of his own. This is a conversation that's been long overdue, and in this conversation, we'll talk about one of the polarizing topics on social media, and that is the role of manual therapy within musculoskeletal medicine and what the research actually says. We talk about how to tease out whether the patient has failed rehab or whether the rehab actually failed the patient. Now, this is a concept that I've stolen or borrowed from Eric Cressy and something that I make sure to emphasize with any individual that I'm working with. We then talk about the critical role of therapeutic alliance in long-term patient outcomes. Again, a concept introduced and talked about often on this podcast. And then we briefly touch on the downsides of social media, as I alluded to before, and the misinformation in rehab and healthcare. One of the new concepts that I learned from Jeremy is the importance of dosing rest in high performance. We often talk about dosing stress and dosing exercise, but what we fail to recognize is the importance of rest and recovery. And how do we actually implement that in the individual who is unable to turn it off? Lastly, we're going to leave you guys with some practical advice for healthcare practitioners, for physicians, clinicians, and anybody working with individuals with musculoskeletal ailments on how you can evaluate the quality of a rehab program and ultimately determine how to ensure better long-term outcomes. Without further delay, please enjoy this discussion with Dr. Jeremy Boyd. Dr. Jeremy Boyd, welcome to the show, man.
Thank you for having me.
I feel like I've had to twist your arm to get you on here. I've only been asking you for maybe 18 months. So yeah. I'm surprised. Even earlier today, I texted you. I was like, hey, it's still happening, right? I wasn't sure it was going to happen. Dude, I want to get right into it, right? I think one of the things that as I was thinking about what I want to talk to you about, I know you and I have had these conversations offline, I don't know, for 10s and 20, 50s, 100 hours maybe. And I was just thinking about what are some of the things on social media in the rehab world, which is where we all live. What are some things that are really polarizing? And you're the king of it depends. And so I'm going to challenge you to ultimately arrive at an answer towards the very, very end and maybe give the listener something actionable about that. But, take your time if you got to get there. I want to start with manual therapy. It seems to be a bit of a cornerstone of how you guys practice.
Yeah. Why
is it so polarizing, that topic of manual therapy amongst physical therapists in general on social media? Why is that so polarizing?
Yeah, my opinions of why it's so polarizing, I like to play devil's advocate on both sides of why some people be on one side of the fence where they're proponents of it and completely against it. Big thing is starting off with the evidence and research, especially looking at our larger studies of like systematic reviews and meta-analysis. The evidence for especially the long-term effectiveness of manual therapy isn't quite there. So I think that's what a lot of people hang their hat on, throw the baby out with the bathwater. It's okay if that doesn't really make any long-term benefits or you don't see any significant difference at 9 or 12 months, why even apply it and everything like that. To play on the other side of things is what studies are they utilizing for this? It's very difficult to have a true homogeneous studies when it comes to manual therapy or really anything in research. But if you look at these large studies, they'll have some where they're describing the manual therapy. Some they don't. They just said manual therapy. So that what could that be? Could that be soft tissue? Could it be joint mobilization manipulations? Some are very sham. And what we were saying before is it's almost impossible to have an actual sham effect or have a sham comparison when it comes to manual therapy, especially if you're putting your hands on an individual. Just the act of that, even if the sham ones, they'll just be like, oh, they put their hands on the individual, but they don't apply a force or thrust or anything like that in the manipulation studies. But just doing that, just putting your hands on an individual in a space of where someone's caring and trying to heal you in a sense, has an effect in itself, or will have a neurophysiological effect. That's, I think, where a lot of the issues are. And also in research is they tend to look at manual therapy in isolation, where it's this manual therapy versus exercise versus education. And they're not saying it's, any more effective than any of those interventions. Now, there are studies that do say that, but then you have other studies that say the exact opposite. But so that's the tough thing. But when you combine manual therapy with exercise or education, which are like the pillars of physical therapy, that's when you see it's being most effective. That's when you see it's, manual therapy plus exercise is better than just exercise alone or exercise and education. There's a lot of studies of the neck, the shoulder, lateral ankle sprains that prove that that addition of manual therapy is the extra icing on the cake that does help people get better faster. So that's it from a research standpoint. I believe those are the big polarizing sort of things. Is again, what research are we looking at and what's its own?
Yeah, a couple questions. I'm trying to come at this with a very beginner mindset. So you mentioned a couple techniques already for what manual therapy can include: joint mobilization, soft tissue work. It sounds like there might be a spectrum here, right, in terms of how aggressive somebody can be from a manual side. One is, can you explain that spectrum? How much intervention can we put when it comes to manual therapy? So if somebody who, isn't familiar with at least physical therapy and how much there is to it, what are the main components of manual therapy? And then secondly, when we look at the research, what are the main end outcomes that we're trying to look at and the main endpoints to really compare manual therapy versus sham versus another intervention?
Okay, good. Yeah, that's a great question, Darsha. So yes, very large spectrum, especially worldwide. You're seeing anywhere from, I don't even know if Reiki is considered. I've seen it. I had a professor try to bring it in as a form of manual therapy. I was like, that's a bit of a stretch. If you don't know what Reiki is really not actually touching a patient. It's like laying your hands a couple inches away from them and trying to move their energy flow. Not very evidence-based. I am a Reiki level 2 practitioner just wanted to learn. I don't know if that's exactly in the scope of manual therapy, but some research will lump that in. But ultimately, it's a hands-on intervention where the practitioner is applying with the intent to, for the most part, it should mostly be utilized in the effort to decrease pain and likely probably in the same kind of bucket, range of motion, improve range of motion for the individual. The typical ones are soft tissue mobilization, which is anything of the massage or instrument assistive, like people say scraping or using blades and that sort of thing, to a joint mobilization, which is applying a force through a joint, whether it's spinal or the periphery. You can do that statically, and that's just a standard joint mobilization, or you can do it while the person's moving, and that'd be a mobilization with movement, or something that's a newer kind of pushes is what we call symptom modification procedures. So the person's doing a movement, let's say squat, and they have pain with their squat, let's say inferior medial knee pain. You're performing a joint mobilization as they're squatting and seeing if you can get some symptom relief. So that'd be like a symptom modification procedure, all the way up to a manipulation, which is a higher velocity thrust. Mobilizations are graded non-thrust techniques. So we're not adding that extra. It's mostly what we call high velocity, low amplitude thrust. So we're adding more of a higher speed component in the spine. Think of things that cause cavitations, which most people call as cracks and pops. There's some other different types of manual therapies, neuromobilizations, where we're trying to mobilize and move the nervous system. And some people also lump in things like dry needling as well, which is probably the most aggressive, being it's the most invasive and getting to further depths of your tissues. So that's the whole spectrum. There's also other things that you can go on YouTube and get down a rabbit hole of like people using plungers and using picks and axes. I don't know if they're using axes. Things get real bad, I guess. They can just chop it off is what most patients say. But mostly, I think the follow-up or the second part of your question is the intent is for most individuals, again, it's for pain relief, range of motions standpoint. The research, I always encourage people as my students or anybody I mentor, Joel Bialowski, who's a physical therapist who does a ton of research in the mechanisms and the physiology in manual therapy. He releases an article, I think once every couple, like 4 or 5 years or so, and goes really into the weeds of like the science behind manual therapy. We're starting to see some other mechanisms at play. It does have an effect on the cardiovascular system. We know that doing mobilizations actually can lower your blood pressure. There's studies of doing manipulation at the CT junction could increase excitability around the rotator cuff musculature, parascapular muscles. Lumbar spine can increase activation temporarily for 20 minutes in the gluteals and the quadriceps. So you could play with that for I'm using for someone who's in a strength and conditioning phase of sorts. But ultimately, most of the research, it's more towards the intent of relieving pain.
So you answered kind of some of the methodological flaws with the studies in terms of when people are, particularly in social media, the naysayers there's two camps, right? So there's the people who are firm believers, and they might be practitioners who are actually implementing manual therapy, such as yourself, recognizing that there's a rule and for every intervention, as you highlighted, and it's very unique to the person in front of you. I want to maybe just talk to or understand the people who don't use it because they don't think it works, right? Because of the reasons that you mentioned, these studies don't really show that, the evidence doesn't really support it, blah, 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 all that kind of stuff. Why do you think, if you've had these conversations at either conferences, these are your colleagues, why do you think they're coming at it? Why are they attacking it? Because the fact of the matter is, majority of the people that you talk to, patients, I'm talking individuals who are hurting and in pain, they'll tell you that there's something therapeutic about that. They don't know why, they don't know what. There's something therapeutic about it. Hell, if it wasn't, you would not have as many businesses and massage therapists and parlors, et cetera. And that's a component of that as well. I want to understand the folks who are attacking this. And some are very respectable individuals. Some I'm a fan of on social media. I follow their content. They put their good content. And I'm just curious. I have some thoughts, and I'm curious what yours are of why they attack it.
Yeah. Again, it goes into polarizing. And some people, I think the biggest part is people are stuck in their biases. They find out what works for them and they do it. And again, everything's in context. I always tell my people I mentor and everything like that, this works for me. Doesn't necessarily going to work for you. Let's say a cervical manipulation and stuff like that. It's based off of, I guess, even the aura, my presence, how I communicate things. So it works for me in my situation and everything like that. But the naysayers, and I'll say this, a really good also podcast is, I think it was Jared Powell's Chad Cook, and they framed it versus Adam Meekins, who's one of the largest naysayers of against manual therapy.
I love that you wrote him up. Sorry. I was actually thinking of Adam Meekins as I was talking about this. He's great. I'm a huge fan of him, but he just trashes manual therapy so much.
Yeah. It trashes it, and mostly, especially from his perspective. And again, listen to the conversation between the two of them. And again, Adam Meekins does a great job of reading through the research and everything like that, and highlighting things and empowering people. I love his saying of "can't go wrong with getting strong," and I do truly believe that. I truly believe in making people more resilient, and more robust, just makes life better. But it's like, how do you get to that? If someone's in such an exquisite or high levels of pain and just lets us load them up, could that make it worse? Can that make them drop off? We always especially research, it's, there's a drop off. We'll just count the people who are in. Why did that drop off happen? Maybe that person was in so much pain, they couldn't even come up for the follow-up in the studies or follow-up sessions and everything like that. So it's something to consider and everything like that. We know with chronic pain, the number one reason people get into chronic pain is how intense the acute pain is one of the biggest predictors of chronic pain. So can we help out these individuals and maybe avoid chronic pain? And I think that's where most of the manual therapy is most effective, in those earlier stages. But a lot of, especially Meekins and some other ones out there, it's a lot of the old thought process of manual therapy. It was so rooted in some of our biomechanical beliefs of, oh, if this and that is rotated, your C1's rotated and your C2, I'm going to rotate it back and I'm this guru, you're going to have to come back to me. And potentially a lot of just the thought viruses you can plant based off of that. Oh, this is that is rotated because I turn my head wrong. What happens if I turn my head wrong again, or I sneezed wrong, whatever it may be? And we just don't really, especially as a practitioner, especially physical therapy, chiropractors, whatever it may be, especially when we're doing a physical exam, the actual reliability or the validity to be able to assess these minute little biomechanical faults when there's really no evidence to support that. I think that's where a lot of it gets thrown under the bus. So a lot of manual therapy is unfortunately tied in with some fear mongering of sorts. You have to correct this or do this. And vegans doesn't really appreciate that. And I appreciate that as well. Is there's certain things that I would say you have to loosen this up or everything like that, or the old school certain profession, like you have to get XYZ manipulated for the once a week for the rest of your life. That's not really true at all. So I think a lot of the hate on it is because of that. It doesn't exactly empower individuals. And the thought is that, oh, this person fixed me versus it going through its natural course of healing and I fixed myself. These gurus who are the cures versus how we really should be is the guide and helping people cure themselves or heal themselves. So I think that a lot of it, there is some thoughts of that, especially in the social media world where people are selling courses and everything like that, where you can say, oh, manual therapy is trash. This doesn't work. Buy my courses that aren't hands-on courses that anybody in the world can access and that sort of stuff. So there is that too. I always throw that in, is who's making these claims. Again, I like to look at all the different individuals. And again, I pull from Meekins. I'm like, those are some great points that he said, and then I'll pull from like Chad Cook or Josh Cleland or Mulligan and all these sort of things. I can choose the best of everybody.
Yeah. Social media obviously has so many different echo chambers, and sometimes that's a good thing, right? When you have a variety of opinions, it can foster debate with podcasts, like you mentioned, Instagram, all these different places where people can go and start seeing different opinion. We might be taking a little bit of a turn here and maybe we go into another topic, but I'm curious, how much has social media changed the way you have practiced with your clients, or vice versa, your clients coming in and saying, hey, I follow Adam Meekins and this is what he says. How do you navigate what you're learning through social media and then putting that into action?
It's a great question. So for me, I'll start off with, I guess, me personally, because it's all about me. No, I'm just kidding. But yeah, I guess by the time social media became a thing, especially from the education space and physical therapy, I was already, I guess, well rooted in other forms of education and already knew who to follow and who's the most respected people of our field. So that kind of helped me filter through things. And it kind of goes back to what I was saying before. I'd start following all these physical therapy influencers or researchers, big practice owners, whatever it may be, and just kind of look at and always take things, just like I'm reading a research article, with a grain of salt, just seeing what is a beneficial thing versus this person's trying to trash something or throw it under the bus or whatever it may be. I was able to do that, but social media is great. And especially I picked up hands-on techniques from social media where I was like, oh, that one looks cool. Let me see if I try it on a student. I was like, wow, it worked. I did try it multiple times before I implemented it on patients. I'll get patients like, whoa, so you're just testing things out on us? So like, to some degree that we do that, but exercises, especially advanced plyometrics, great strength and conditioning programs. So there's a lot of awesome resources out there. I just tell people to diversify and everything like that. You don't want to just go and blindly follow somebody. Again, usually a lot of these influencers have their own biases and stuck to it. From a patient perspective, I don't know if it's helped or harmed people. I've had a patient recently that straight up said to me, actually after a little bit, we just got into a random conversation about it, was talking about how the classic do these for back pain, the strict cure your back pain exercises or modalities, and tried those and wasn't getting any better. And then that added more fear to her system, was that she didn't get any better, and the hopelessness started to increase as a result of that. Everyone who followed this mega person or whatever it may be, and why it didn't work for me. And is there something more seriously wrong with me? So those sort of things, I think that especially those absolutes like, oh, this is going to work for everybody, or do this is the only thing that works. That I think I've never been a big fan of that. People have always asked me like, why don't you do certain series to help out ABC pains? And I refuse to do it because there is no exact, if we had an exact package for the cure any sort of pain, that would be out there as common knowledge. You probably learn it in high school or something like that. But the complexities of every individual with pain is impossible to just package up. You can say, hey, there's some commonality. Yes, we probably should post-op ACL and that sort of stuff. There's highly likelihood that we're going to have some weakness and atrophy of the quadriceps and the hamstrings. You should probably do some quadriceps hand strengthening exercises. But maybe there's some other ways that a particular patient needs to work on, or some other different avenues. Like maybe that person doesn't want to strengthen those muscles because they have such a high fear around their knee that they don't want to move it. So I need to access that first versus just putting these out there. The person tries it flares up their knee, and now they're taking 2 steps back. So that's probably the negatives of it from a patient perspective. I've had some patients where they've picked up some good nuggets here and there, especially from things where people put out like the one big benefit of social media is starting to empower patients and starting to take away a lot of the fear associated with like pathologies, especially herniated discs, meniscal tears, small rotator cuff tears, where a lot of that's coming out, where it's just like you can get to an asymptomatic state with these conditions. So I think that's good. That's getting out there and starting to educate people that you are not doomed for this, that you could be active and be healthy despite having this pathology or diagnosis. So I think that's the real benefit from it. But yeah, that's just
One of the things I like to tell my trainees, really anybody that I'm in a relationship with, where I'm educating them, sometimes even the patient, is it's very important for us to go through this journey. This intervention that I might do for you, it's really important for us to pair this up with a good quality rehab program. And I'm very specific with the verbiage I'm using because I want to emphasize the importance of a good quality rehab program. And I have some ways that I try to make that point where somebody goes to physical therapy, they come back to me, right? I always make it a point to tell my trainees, hey, I want to know where they went and what they did and how long, right? I want to know the very specifics of the rehab program because we can't assess if the rehab worked or not if we don't know the quality of the rehab. And I have some thoughts in my mind of how to do that, and I give that to my trainees. So I have a 2-part question for you. In your opinion, what are the components, some of the key components to a good quality rehab program from your perspective? And then what advice, what things can you give clinicians, physicians in particular, who are seeing patients after rehab, where they can assess if a patient's been through a good quality rehab program?
it's a great 2-part question. I'll answer. So the first question is basically just what you're saying is what defines a good quality rehab, or what people should look for. Ultimately, a practitioner, physical therapist, sometimes now we're having chiropractors become part of the rehab space, athletic trainers. So I don't care what profession you're a part of, that you bond with and that cares about you. And likely with that, you're going to need some continuity of care. So 1, maybe 2 practitioners at a practice. So you're not like bouncing around seeing 4 to 5 different individuals, especially because we should treat with some degrees of a biopsychosocial approach. I think all components of pain have a psychosocial element to it, regardless of the simplicity of it. Let's say we always chalk up ankle sprains as a simplistic injury and everything like that. But even that is rooted in some cognitive and some social elements, especially for an athlete. So I think having one practitioner or one main practitioner there talking to you, understanding you, is probably the most paramount thing. And there is studies, we call a therapeutic alliance in physical therapy, which actually I believe is stolen from nursing. Now, you can be a very relatively mediocre clinician, but have exceptional therapeutic alliance, and your outcomes will be really good. And vice versa, the opposite. You can be a phenomenal clinician, but your therapeutic alliance, your ability to bond with someone is poor, your outcomes will be poor. So I think that's the most paramount thing. And then you should be making steady progress. Your program should evolve with your progress. So a lot of, unfortunately, is stigma or the norm of physical therapy is you start on a program and then 3-4 weeks go by and you're still doing relatively the same thing. Well, pain should change, your range of motion should change, or your goals should progressively change. So the program should change as well. So seeing that evolvement go through things, I think is especially a big piece, in making sure that you're getting challenged. I think is the main thing. It's like you want to be pushed in some degrees. Obviously, in those earlier stages, we have to have the fire situation. So it may not be as mostly intense exercises, but heck, in those stages, just moving around is intense enough. But you should eventually get challenged so we can building up more resiliency. Ideally, hopefully, get you out stronger than you've ever been. So I think those are really the main components, and just make sure there's also a psychological side of things. So I guess second part is you said what a physician should be asking for, or
Yeah. So one of my favorite quotes from Eric Cressy, I think I saw him on Twitter talk about it one time, is we often say the patient failed rehab. And he talks about how that's typically not the case. It's they had bad quality rehab and the rehab failed the patient. And
Yeah,
so
I agree.
that's just stuck with me for, I don't know, 5-6 years since I saw him post that. And how do I assess if the patient failed rehab or rehab failed the patient? It's critical for somebody like me, because if we're going to decide that we're going to move on to the next step in the conservative management algorithm, whether that's injections, as you mentioned, whether it's going to be orthobiologics, whether it's going to be a surgical consult, we need to assess if that first intervention, which was rehab that we had agreed on, did it work or did it not work? And if it didn't work, why did it not work? As a physician, what are some questions we might be able to ask the patient? Because that's really what it is, right? We have, ideally, you have that relationship, like you talked about therapeutic alliance, you have that with a physical therapist as well, where you guys can communicate. You and I do that. Your team does that with me all the time. I love that. But maybe the physician doesn't have that. Maybe they're not willing to pick up the phone and get that sign out from the physical therapist.
Yeah.
What are some ways that they can gauge the rehab?
Yeah. So I guess right from the top, just what are you doing at rehab is a good start. If it's the outdated approach, it's, oh yeah, they put a hot pack and I ride the arm bike for 15-20 minutes. I think that right there is a red flag. Tell that person go far away. Chris Carroll, who you've had one of our PTs, he'll go on an hour-long rent on the upper extremity bike there. And so seeing those sort of things, or a lot of use of the low-value modalities of like E-stem or ultrasound. Again, these are things that we once thought worked in the 90s, maybe the early 2000s and the 80s. If that's how they're still practicing, you're starting to hear those signs. It's like, all right, maybe this person, maybe rehab in this situation did fail the individual. And it's like, going back to what I was saying before, is have they challenged you? Have they asked you to, how are things coming along? Are they trying to modify the program to meet your needs out there? So I think those are the main things. And looking at from a patient perspective, did the patient fail the rehab? The main thing is, did they show up sort of situation? Like a lot of times, like people, they're told to go to physical therapy, and I used to live in this fantasy world that people can go 3 times a week and have the time to do it, and then also have time to do a home exercise program. And it's really almost unrealistic for a lot of individuals. They're busy, they're parent, they're working full-time jobs. Even kids now, I thought at least the kids can do that sort of stuff. Now they're getting shuttled to 3 different practices. They have band practice, they have chess club, whatever it may be. But they at least should have some consistency. Did you go away multiple times? Did you do the things that you said where you're trying to be pushed? And sometimes they are doing those things and progress isn't made. And I think it should be the PT probably making that call before like the follow-up perspective. So at least maybe the physician doesn't need to get back to the PT, but at least a couple of weeks in, the PT's not seeing any progress. Obviously, we want to see progress with everyone, but sometimes we do need some help. I lived in this fantasy world. If you come through my doors, I'm going to cure you. And that's not the case. If that was the case, I'd have a line outside wrapping around the town and driving a Ferrari. Wait, there's all these other beautiful interventions that can help, orthobiologics, surgery at the right time, even medication. We throw medication under a bus, it has a time and its place for it. Obviously, I want to get people off it as quickly as they can. But if we're not seeing the progress that we're expecting to make, and it should be evaluated on a session by session basis, but within a week, we're not seeing anything, but definitely within 2 weeks, you're not seeing progress. PT should probably be the one that's giving the physician a heads up. At least the patients try, we're doing everything on our end, but it's not taking situation versus the physician just going, I don't know. But I think big ones are where you challenged more updated of interventions, especially from a loading standpoint. A lot of practices are keep using TheraBands as their main source of pushing a patient, even regardless of age. Like we unfortunately silo off the elderly and the geriatrics. So yeah, that's okay for them. In reality, they should be squatting, deadlifting, doing blood pushes. So they should be challenged just as much as athletes themselves based off of their capacity. So listening for those sort of things, but mainly with the patients is that they show up. As long as they show up, I think that's all we can ask them. If they're one of the individuals, let's say, I'll knock like runners, CrossFitters. I love them. I do CrossFit and I run as well. So I have these tendencies as well, but where it's especially for an athlete perspective, you're telling them, all right, you need to go to rehab. I need you to listen to them, maybe ease off of your training regimen. And then you go and you start talking to them and they're like, yeah, I'm still going to CrossFit 6 days a week on 4 hours of sleep. Again, it starts to go on the patient probably too. So you make the appropriate lifestyle modifications for rehab to be successful. So those are big ones. They show up and they make the actual appropriate.
I want to double click on this idea of failing rehab as well as showing up. I practice in an inpatient rehab setting. And when I screen patients that come in, the one thing that I cannot assess most of the time is their motivation, their ability to participate in therapies. And our goal is to get them back to their prior level of function as much as possible. But sometimes I might only have 7 or 10 days to do that. They start off day 1, day 2, and we start to see that, hey, they aren't motivated. They aren't willing to put in the effort that it might take to get to where they need to be. Yet they're there, they're showing up because they can't leave, but they're not exactly participating. In those situations, how much of the onus is on the patient? Like, how do you view that concept of failing rehab and making adjustments? Because there's also times where I might have a patient return for the second or third time, and we might actually have to deny that patient because they quote unquote failed rehab the first 2 times. They're going through the cycle of hospitalizations, chronic disease. I want to understand, I guess, from your perspective, the fairness of that and how much physicians, therapists can do to really get a patient to where they need to be.
That's a great question. So I worked in inpatient rehab, so I get a feel for it. But even in outpatient and everything like that, a competitive spirit, trying to always improve myself, regardless of what comes in. We get a lot of people who don't have that willingness to change. I always sort of thinking like, what are the magic combination of things, of education points, of bonding points that I can say to get this person to make the flip? And also I have to, like, in the back of my mind, know that people are sometimes not ready for it. That, which was a tough pill for me to swallow, and I still have to take it every once in a while. Adrian Lowe is one of our exceptional researchers on pain science in the physical therapy space. He said himself, some people are just not ready to change. Some people are not ready for the education and everything like that. And I believe Dr. Fatima, that you just had, she made a point. When I heard that on your guys' podcast, I was like, I say the same thing to my students: is some people have to hit rock bottom. So sometimes they do need that second and third unfortunate go at it before they are willing to make that change. As clinicians, we're always going to try and, all right, how am I going to get this person to be motivated to do this sort of thing? Like, how I get them, obviously, with their program, they get salient and important to them and everything like that. But even that sometimes isn't enough. But I think that, unfortunately, hitting rock bottom is unfortunately a powerful motivator. I wish it wasn't the case. I always try and get people away from that. I used to say, oh, my frequent flyers back in the day, I don't see as much of them because I believe I'm more impactful earlier on. But some people, maybe that's a flaw as me as a clinician, are still like that, where it's just like I'm giving them everything that should work, but it's not. And they're not making the that change I was hoping for. And some people, it's just like tough for them. They almost negotiate with their lifestyle. I'm telling someone, hey, they need to decrease their workload and that sort of stuff, and they get used to it. And there's maybe some things on the back end that are motivators, especially from like athletics and weight loss and everything like that. So we can be saying all these sort of things, but in the back of their mind, no, I need to keep exercising to make sure I don't add weight or whatever it may be. So sometimes they have to get to that point where fortunate does stop them for a long period of time before it really settles in. So I'm always a believer in second and third chances. Sometimes people are 4 or 5. I'll never give up on people. I know I've had some mentorship sessions with some of my PTs where it's just like a person like keeps coming and I don't know what to do. I'm like, you keep giving them the good word, and one day maybe it'll finally click. But make sure obviously they're screened and they're appropriate for physical therapy, and they have a good team around them that's also supporting them. But a lot of people, especially their traumas, are so deep in the limited time, whether it's 7 to 10 days or hour or 2 in outpatient physical therapy, it'd be unrealistic to really get down deep into this traumas. We try our best. I've had many 3-hour-long sessions with people, but you're talking about stuff that's buried many years. I'm a big fan of try to keep giving them second, third chance. As long as they're appropriate. There's certain situations where it's like they're not doing well because we're not the appropriate practitioner in the situation.
Yeah. A while back, I remember maybe a couple of years ago, AC Sinkowski, she had posted on, and I'm not sure if you're familiar with her, but she's a nutritionist, previous guest here, really awesome. Shout out to her. She had talked about, people make changes in their nutritional habits. And I think something to the sort of when, people change when they're sick and tired of being sick and tired, which is kind of what you're talking about, right? Hitting rock bottom. I remember hearing that the first time and I was like, wow, that actually is really powerful. And we do need patients to be active participants in the care. This is what I tell them now, right? Yes, I can inject your rotator cuff tendon sheath and it's going to help you temporarily, but this problem is going to be a problem probably for the rest of your life unless you do something to get a handle on it and do a maintenance program indefinitely. But I also remember, and I'll share this with you, at the struggle that I had, because just before that, I had read a book, Changemaker, John Berardi.
Oh yeah,
Big fan of him.
Or listened.
Yeah, and there was this quote in here, which, man, it gave me all the good feels. And that concept we're talking about, people hitting rock bottom, it's almost to the saying, you can lead a horse to water, but you can't make him drink. John Berardi said, great coaches make the horse thirsty enough that they want to drink. And that really hit me deep, right? Because I was like, man, that's inspiring, right? Like you're injecting some type of motivation into this person that they're going to want to change, right? And I was like, man, that's what I want to be. You want to be the change maker, right? That's just like he's been. I think the reality is we, as our recent guest Denzel talk about, work reaches a comfort and convenience is really infectious. And when things can be done to us, for us, pair that with instant gratification, not being patient. Everything we talked about in terms of rehab, that process takes a while.
Yeah.
Or it's like 6, 10, 12 weeks and then indefinite versus an injection and you'll feel pretty good in 3 or 4 days. You take all that into, and it's not really a recipe that is designed, or not a framework that is designed to get people into buy into that rehab process and be active participants. And I think the reality is you have to find the people, even those people that Berardi was talking about who you might get thirsty enough to drink, they probably had something within them that you were able to light up, like a spark. But if there's just no spark, if somebody just doesn't have buy-in and they're just not ready for rehab, then they're just not ready. And when they do hit that rock bottom, like you talked about, they'll come back to you. And if they're lucky, they won't. But depending on how the musculoskeletal chronic disease burden is going and pain is, pretty much everybody does. So I think that's something that for the young physicians, young clinicians who are struggling with that, who are big into motivational interviewing and coaching, because that's really what we're talking about, coaching. You're talking about coaching with your patients. I'm talking about coaching. That's something to keep in mind.
Yeah. Super powerful. It's a great quote. Should probably send that out to the team. So I've heard we can make the horse, lead the horse to water, and then we can try to stuff the horse's head in and try to drown it in the water. Like that's not the best approach, but yeah, I think that's where a lot of the therapeutic lines and bonding comes to play, where if you have an incredible bond, especially with, I always say, what makes like the greatest clinician is someone who can be so dived in the research and the training and the mentorship that they forgo everything else in their personal life, and that would make them the GOAT clinician physical therapist? Or is it someone who has also maybe isn't so far into that, but has also a balance into real life sort of things that we tend to bond with people of similarities to. So sometimes it's just, you just need to find that right person that can light that spark. And so I'll be honest with patients and everything like that. And so that's why I like having a team, and I like to also treat around. It's been a little bit since I've treated around the other staff because they've been bounced around in the other offices, but being around other people and they can hear like we all have our own different style, and that can attract someone to potentially make a different change. If there was someone who's, we have one clinician and he's super like high energy and motivating. I remember, and everyone loves him, but the one patient, young girl, asked to not be with him. How do you not love being with him? And she's in the dumps, having an Achilles tendon rupture, and he was here, and his patients thrive off of that, but it was not what she needed. So we made the swap, and she eventually did a couple sessions with him when my therapist was on vacation and stuff. But it blew my mind. I'm like, everyone in my family sent to him, but that was it. It's just like, she was here and he's here, and that's something as simple as that.
Interesting. Yeah, the energy mismatch, really, right? That's important too.
I tell people that I encourage people to really improve their mental. I really am a firm believer, if you got to treat almost in between the ears in order for rehab to have success. And I guess physical therapy has the knock on it. It's a jack of all trades, master of none. Some conversations like counseling and therapist and psychology. We can do manipulations and stuff like chiropractors and osteopaths. We can even needle now, like acupuncturists. We can do a little strength and conditioning, like office strength and conditioning trainers. And so we can't get a knock for that. But I really do think that's the beauty of us. And it's this, better I get at these skills, the better I get referring to individuals and picking up on these sort of things. And often, unfortunately, mental health practitioners is, I didn't bond with that person. That person wasn't for me. I never did it again. I'd say that's over 75% on the proper statistic of the individuals I refer to. Like they tried it once, it didn't work for them, and then they never shot it again. Like it takes a while to find the right person. It goes for anything in evolved medicine. Take the time to find that right individual that you bond with, and hopefully they have an exceptional personality that works with, and also exceptional clinical skills. Hopefully you get both. But I think that's the important thing, is finding that person that works best for you.
I love that reframe that you have, though. I think maybe something I'm thinking through now as you're talking about this, I think maybe what makes you guys incredibly successful in the team that you've built is maybe because you guys are the jack of all trades and master of none. And maybe the reality is that most patients in rehab, that's what they need. They don't need a master of one trade. They need a jack of all trades. Because if you get them to, it depends on what phase of the rehab, that you get them to the world's greatest strength and conditioning coach, right? Just high level person, but he doesn't know how to create that connection, therapeutic alliance that you're talking about. And then at that athlete's having a bad day off the outside of the gym, and you can't get that person to get dialed in because you don't know how to have a conversation and treat being between the ears, as you talked about. By the same token, you pair them up with the greatest psychotherapist in the world who's had success with the high performers, all that kind of stuff. But they're 2 weeks post-op hip and they need some mobilizations or some reason. You could talk to them all day and get their positive psychology and mind right. But that hip needs to be mobilized a little bit, right? We got to create some stuff there. So I think maybe for those like later stages in rehab, and maybe not even in rehab at that point, which is why I remember you and I talked about at some point, I was like, hey, you guys still do programming? And you're like, nah, I think earlier on we do. And then we start referring out. And now you need to, I can carry this torch for a little bit, but now I need to pass this on to somebody who can better serve you because this is what you need. And I'll be here periodically for you to check in, but you can graduate, so to speak. And I also want to I think that's also refreshing in this world, particularly of healthcare, where everybody is so hyper specialized. I don't know, Darsh, I'm curious to get your thoughts. I know you're going to have thoughts on this. Is in medicine, everybody, like I'm subspecialized and everybody has done a fellowship at this point. The trend in physical medicine rehab residents are not to go into practice, primarily go into a fellowship afterwards. And it's, you come in, somebody comes in for pain, and let's say you're a shoulder surgeon or shoulder elbows. I treat shoulder elbow. I don't treat the hand. Sorry, go see the hand guy. And sorry, that's not my problem. You know what I mean? And pain and human beings are very complex, and you need to address all the facets to treat health overall. So yeah, I think that's a beautiful thing. I agree with you. And I think that reframe is powerful.
Yeah. It's actually my favorite quote, because a lot of people don't know that it's an unfinished quote, but it's a jack of all trades, master of none, but oftentimes better than a master of one. And so my leading principle in life, honestly, is to build range. And I think there's a lot of anecdote stories now, even some data talking about how if you're able to build range, you're able to have a diverse set of passions and skill sets, you're going to oftentimes become better and be at, like, quote unquote, the top dog in your field, because now you are able to pull out so many different tools from the toolkit to help and to build whatever you need to do. Great book by David Epstein called Range, even the book Mastery by Robert Greene. I think both of those really highlight in today's world where there's just so much out there that you can now learn and obtain. You talked about you just had a Reiki certification, right? Just because you were interested in learning that, but that gives you an advantage, because there's probably going to be some patient comes in and just says, hey, what about this? And you having also that Eastern philosophy a little bit will help you with your patients a little bit more. But I agree, ultimately, I think everything is getting a little more siloed. And I think we're starting to see the pendulum go the other way a little bit in medicine. I feel like most physiatrists now are actually going down more the general route rather than fellowship. One, because of the time, the investment, and just the ability to have that lateralization. If I get sick of inpatient, I can go do outpatient, I can do injections, I can have the option to do a lot of different things. But yeah, sometimes mastery, it blinds the practitioner, blinds the patient, and they're not able to get everything that they may need. So I'm a big fan of being a general and scoping out the field.
Yeah, I think especially with, obviously I treat people pain. I guess as specialized as it gets in the physical therapy space. I've went through residency, went through a sports manual therapy fellowship. So that's even subsection of orthopedic manual physical therapy. But pain is complex. It's multifactorial. So our treatments should be multimodal. So we should, whatever, you have some patients where it's just, I don't touch them at all. They're just exercise. And some people, I have the ability to just talk to patients. Without a doubt, I've had multiple 2 to 3 hour sessions where I never get them past the waiting room. I have other patients coming in. I'm like, we probably should have done some exercise at this point. But at that point, that person needed some more conversation pieces. So that is the beauty of, especially physical therapy, where we have the space to be able to do all these other things and have the squat racks and everything like that. But something I always encourage is the same thing that you guys say. I don't know if any prospective student physical therapists are listening in and everything like that. Typically the students that are like, oh, I picked your place or want to go to your place because you're a sports place and that's all I want to do. I can't remember any student of that thinking. Maybe 1 or 2 that were just dynamite. But typically the greatest students, in my opinion, the ones that we've hired and everything, are like, I just love this profession. I don't care if it's inpatient, geriatrics, pediatrics. They love it all. They take a piece from it all. And I do think that's super beneficial. You can bring up Chris Carroll, who has his own private practice in spinal cord injuries and neuro-based rehab and strokes and all these sort of things. But he blends so much of what he gets on the sports and orthopedic side into that. And they have outcomes that are unforeseen in the field. I know a guy, Steve Kenny, who's, I forget where, somewhere in the Midwest, where they have 1 PT for every, I'm being a jerk here, but like 100 miles or something of that nature. So he has to know the cardiac system, integumentary, neurocognitive, all these sort of things. And he's able to treat everyone. He's a phenomenal physical therapist as a result of that. So I do, if I can give any advice to the younger generations, is be open to everything, because surely when you treat the human, it's the whole system. So don't silo yourself off just to one part. Like, continue to push your knowledge and everything you can learn about.
I love it, man. think what we're talking about is just, we're all in the business of helping people, and you got to take out the tool they need to take out in that time to help the person with the situation they're dealing with. And typically you try to do it, look at it from that point of view, you're going to have some success. Just to recap, I think the components of rehab program that you talked about, number one, and I'm not surprised at all that you talked about therapeutic alliance. So building that rapport, creating connection, another powerful word, with that patient, maybe the most important thing. And then for better or for worse, progressive overload. So varying program over time, not being stuck doing the same thing that you're doing today for 4 weeks unless something's not right. Is that adequate? Those two main components that you looked at?
Yeah, I think that's the main thing. Like, again, you want them to be challenged. I think that's a lot of the knock on rehab. It's like most people say, I could have just done it at home, sort of the situation. And that's not how it should be. One, either you're paying with time or actually out of pocket or whatever it may be financially, like you should be given more than what you can do at home or what you can look up on.
That being said, though, I think one thing I would add is something that I do look for is part of the rehab program is homework. And I'll have patients that, how often do I need to go? And rarely will I say somebody needs to go more than twice a week. Now, again, there are exceptions to the rule, right? Post-operatively hip, I had my hip done. I did my rehab with you. Full disclosure for the audience, I was seeing you 3 times a week earlier on. That's what we need, right? You need a higher dose. And this actually good segue into the next topic I want to talk to you about. I knew we wouldn't get to some of the stuff that we wanted, but that's okay. So dosing exercise and dosing rehab. So Dan Pope, we love him. He's been on here a couple of times. I'm sure he didn't coin it. This concept of dosing exercise is what I learned from him is very important. Actually, I think what he talks about is dosing stress. And we can talk about exercise being a physical stressor, maybe a psychological, emotional stressor. And you have to balance that with other stresses in your life. And over time, you have to increase that dose so your body can be more capable and build capacity. You talked to me about something a while back, and you were talking about dosing rest. It was mind-blowing to me, and maybe this is a bit of a cue where I think you were telling me about somebody who was going on a vacation, and after 2 days, it was like an 8-day trip or 9-day trip, and the person started losing their mind. This is somebody who is always go. Is that
starting to ring a bell? Yeah.
Why don't you go into that concept? Because I had never thought of it that way. So for that high performer type AA person that you take care of a lot, most of my healthcare colleagues, medicine colleagues, how do you dose rest?
Yeah, which is it's just a tough thing, and it's a tough thing to negotiate as well. Once you start to explain things and having that story as a patient or having a patient like that, it's a lot easier. But we have these posters, they're called the Twin Peaks posters. I can run and rip them off the wall to kind of show you guys or send it to you guys for the notes and everything like that. But it explains like your capacity of stress, whether it's work stress, physical stress, mental stress, all these sort of things. And when certain individuals, like you said, like providers, I see a lot of business owners, elite athletes, where they're just always operating up here. It's one, you're just in that fight or flight, sympathetic drive response all the time. And which is probably most likely a big cause of why you have to come see someone like me or you. So it's a big threat to the individual because they're used to it, of always operating like that. Whether it's my business, I have to do all these sort of things, or even something as simple as like the ultimate mom or dad who's, I got 4 or 5 kids, I'm taking them everywhere, I'm working a full-time job, whatever it may be, to say, hey, I need you to take a break, or I need you to shut down from the sport, one that you're just going to set alarm bells. You're now changing their organized chaos. And that's going to, again, when we set off alarm bells, that's going to increase pain sensitivity. So that's even going to make things worse. So to give things just like we dose anything else, exercise, pain education, I used to give it like verbatim, like a full hour-long talk after my evaluations. And some people it helped with, and then a lot of people were like, screw this guy, I'm never coming back to him because I didn't have the right dosage. So we have to give these little bite-sized, these crumbs for people to pick up the trail and be like, okay, I'm picking up what you're putting down. It's starting to get a little bit better and everything like that. For those individuals that are like that, it's not everybody. Certain people you can just be like, okay, I need to take a week off, and they're cool with it, and the body responds great for it. But those extremely high performers, it's just, hey, You're used to operating like this. I just need you to kind of wave a little bit of a break and then come right back. And then we're going to extend that window. It's okay. Maybe just plan to end work at 4 o'clock versus 8 o'clock. And then we'll work from there, sort of situation. And then like a lot of times we have that, I like a negotiating piece for these individuals. Work till 4 o'clock. Instead of being on the desk, I want you going for a walk while you're on the shoulder, sort of situation. So instead of fully cutting the cord and that sort of stuff, because again, that meets a lot of resistance. You have to bite-size those and then start to extend that window. And the body ultimately wants to be in a more of a balance, probably mostly a parasympathetic state. But if we do it too much too soon, it's gonna cause all the alarm bells to go. So little bit by little bit, and you get a gauge as a clinician of like how much you can negotiate with the individual based off of what they say. If they're like, I haven't taken a vacation in 6 years. Okay, start off very little for those individuals. For the people like it's been a month or two, it's like, all right, why don't you take this weekend off? Sort of situation. So I think it's super important. I think a lot of people, especially in the United States, where practice and just today's day and age, it's so go where we need to get into that parasympathetic kind of state. Because people they're waking up, they're driving, and then it's like they go to sleep thinking about the next day. It ruins their quality of sleep. That ruins the hormones that are produced. That the growth hormone, growth-like factor, those are getting disrupted, and then they're rinse and repeat. Cortisol is going to be a shooting up and everything like that. So we need to get to that state, but can't all be done.
Is there anything you're recommending to your clients to get into more of a parasympathetic zone, given that even if they're taking a break and they're type A, they might still be stressing about the fact that they're not doing something, or they might substitute exercise with another high stress chore?
Yeah. Well, first things first, I tell them that they owe it to themselves, because most of these individuals do not believe they deserve to have a break. Something's rooted. They were pushed when they were younger to go, whatever it may be. First thing right off the bat, get a dream between the ears situation is that they owe it to themselves. I always give a lot of it's like they're internalizers. It's a lot of times it's people who want to help out others. Those are the main ones. It's very rare. Sometimes you get some maybe narcissistic individuals, but it's usually individuals who are just trying to help out others. And they're like, whether a business owner, I'm going to do everything for everybody. I'm like, I always give the analogy of the airplane. I probably say this, I don't know, once a week or something of that nature. It's on an airplane, when the masks come down, they tell you to put on the mask of your kid first before yours. You have to, or you put yours on before you put the kid, right? Messing that up. Why? Because if you can't help yourself, then say you put it on the kid first, you pass out, then the kid's in trouble, such and so forth. You got to help yourself before you can help out others. So I say that right off the rip first, and that usually hits home. Saying that's the main thing, and then kind of engaging things of what they're okay with doing, sort of stuff. Again, sometimes I'll start to say, I'm like, yeah, why don't you book a massage or try and do a meditative walk, and you just start to see it like glass over. All right, let's do just like a cardio sort of thing, like a bike ride or something of that nature. So again, you have to meet the patient halfway, and I explain to people, it's like, also the expectations around it. It's not, you're going to take one day off, or you're going to modify something and give yourself a little bit of a break, and then your pain that you've had for the last year or 3 months is going to disappear. Like, no, that's not going to be the case, but it's a piece of the pie. I just try and meet them halfway, figure out something. So I got to tell people, maybe it's my biases of massage and manual therapy. I'm like, get a massage every once in a while. It's good for you. Maybe you'll pass out. Get a little body work done, nice calming environment, nice smells. But I usually try and tell people there's a lot of evidence and research for meditation. I'll tell people like, you need to be like completely, the world is just completely blank. I'm like, no, just get in a meditative state of where you're just devoting time for yourself to be to your thoughts to so degree. But I'm trying to get to a peaceful state. So those are the big ones that I can promote. Yoga, mostly because there's a movement component as well. Sometimes it's just like listening to music, jamming out. It's like you want to find something just like the exercise mode. Like a lot of people, especially when I treat it in an athletic population, it's just, I always try to get people to be active in fitness. That was the discharge goal. Now it's everyone's active fitness. I have to get them back into it, but they're always like, what do I do? I'm like, whatever you have enjoyment doing. That's the main one. I don't care what mode of exercise it is. As long as you enjoy it, you're going to consistently do it. So whatever type of, I'll list off some parasympathetic based activities, whichever one kind of hits home for you a little bit, go for that. You jamming out to music, go for it. A walk, go for it. Drive it around in your car aimlessly, go for it. Whatever it suits your fancy. Yeah, so the same thing. You may miss the first couple activities, but you'll eventually find something like, this is good for me. Coloring, whatever it may be. So I try and leave it open for the patients.
I think we're all familiar with the person, and in my family, I am that person where, you, or somebody might say, like you talked about, who has been hustling for 5 years, right? Just trying to start up a business, start up a family, young entrepreneur, young healthcare professional, might be residency that you're coming out, 4 or 5 year residency fellowship. And then somebody says, okay, well, let's take a 2-week vacation off. You don't even know how to do that. As you said, organized chaos. Like your system is used to that organized chaos. That's the baseline. And we know a big stressor for somebody is like a difference from their baseline, what they're used to, right? That in itself is stressful. So if you're just used to go, and all of a sudden now we completely change that environment where you're not doing anything, that in itself can be problematic. You might find that you were coping and not having time to think through some emotions. Darsh and I have talked about this as, can you sit quietly by yourself? You might find that you have some scary thoughts when you sit quietly by yourself. You might have some loneliness that you weren't ready to handle. And that could open up a different can of worms. Might not be good. And so I think just micro doses initially and figuring out where that person is and what that person needs, and then expanding on that dose, just like we talk about building exercise, progressive overload on training, but we also do progressive overload on this parasympathetic. Chris Williamson talks about, we did a David Goggins type, nobody can rest harder than me. But I think before you get there, most of those type A people need to slowly be introduced to that. And I think once you said it, I started thinking about it myself. If I'm not that person who's go, probably no surprise to anybody who listens here, but if I go on a vacation, by day 3, I'm getting itchy. I'm getting real itchy if I haven't done some type of work. And I was thinking about this. I think Darsh recently posted on Instagram at some point about self-love is, what is it, that first thing that you need to do to get yourself going? And I love to train, and I want to train in the morning. There's some benefits to that, I think, for me personally, because I have that out and I don't have that in the back of my mind. But lately, and just because I have some other projects on my plate lately, I think I've had this mental load of things that I need to check off for various projects. Lately, what I found for me, self-love is, and thank you to Darsh for doing this, is when I first get up, is I do not go to the gym. I still get up early, but I want to take care of the administrative stuff of those projects that I got to do. And then I feel so much better after work. And I come home and I can be engaged with my child and actually be there because I've taken care of the administrative tasks, but I can go to the gym afterwards too. I'm still training and doing that kind of stuff. And so at this point, dare I say this, it's maybe even more important from a mental health perspective for me to take care of that than my training. Training is still, it's habitual, right? I don't have to get fired myself. I recognize the importance. That's like brushing my teeth. So I think that's another piece is you have to find what your dose is, and then what's the minimum effective dose, if I may say that you need to get yourself into that parasympathetic comfortably.
That's great points. And knowing that you might get a little fight back sort of stuff, whether it's being alone and you're getting these thoughts and everything like that, or maybe increased symptoms, and it's just like anything else. Sometimes when I do progressive overload exercises or even manual therapy, that's progressive in itself. We start to push the envelope a little bit, and sometimes we get a little fight back. And that's okay. That's part of the healing process. A lot of the protection around things and the sensitivity around things. Well, what are you doing? Increase the pain sensitivity or the sensitized experience. So it's being like just communicating that to individuals, especially when things are, it's like, it's my identity to be this. I felt that as well. It took me till, I don't know, probably year 9 or 8 or 9 of practicing before I could really relax, especially being a business owner. Just have all the phones go to all the calls go to my phone and everything like that. So 8 or 9 years of practicing before I can actually start to truly relax on a vacation, where it's like I wasn't answering things or sending DMs or checking in and that sort of stuff. I still do it now, but it's I have to, but it was part of my identity. It was almost like I shouldn't be on vacation. I should be grinding and that sort of stuff. But even when I'm on vacation, if I'm grinding, I'm the man for it. And it's like reality. It's just, yeah, sure, that's cool. And you can have the Dave Goggins kind of thought process, but at what cost is that? Is it coming at the cost of the drive of being in a sympathetic state? Is that going to affect my heart? Is it also going to affect my relationship because halfway across the world and I'm thinking about work when I should be thinking about spending time with family? Because they'll pick up on that sort of stuff. It does take time to do that. And I think that's an important thing too. Like, especially rehab, we're boxed into 2 to 3 times per week for 4 to 6 weeks of the classic script and that sort of stuff. And you deal with people who've had things for many years, sometimes longer than I've been around as a clinician. I've had people with 30, 40 years of issues and everything like that. To say this is just going to happen in this case that you're here is probably unrealistic, but we can make the small steps towards that. You start spending 5 minutes by yourself situation, and then you'll start to see the value of it. And then who knows, in a couple of years, maybe you are taking a vacation or you're working only 20-hour work weeks or something of that nature. Yeah. It takes time.
As opposed to 20-hour work days, huh?
Yeah, exactly.
Hey, Darsh, I got a question for you, man. You travel a lot here. Do you find yourself ever getting that itch that you need to do something work related?
Yeah, absolutely. I still do. So it's funny, like even during the day now, like I've noticed that if I get to write something on Threads or if I get to put a content out there, then, oh man, it's just like this wave of relief. Like I've accomplished something. And so even when traveling, I know going in, I try to make that like my deload week where I'm just not doing anything, or I can just do a couple push-ups and work out with Mira or something like that. So I try to go in purposely and say, hey, this week is going to be a deload week from a training perspective. But I do tend to write in my notes about things that I philosophize over that I can then come back once I'm back in the US or back home to then make content or then act on those things.
I'm going to actually steal that. I'm stealing that and repurposing deload, because deload is in the context of training. But I think deloading from work.
Yeah.
Right? Let's look in to see if that happened. Let's trademark that for us. But I think that's what we're talking about. Because I think completely abstaining from that. We don't want to necessarily abstain from exercise. We know that. And so we deload and every now and then taking some time off. But I find myself, if I just deload and decrease the intensity and also the duration on the vacation time, like everything the vacation becomes much more enjoyable. I think when you have those high performing individuals, like they have that itch that needs to be scratched. We're big fans of Alex Hormozy, and I don't think that guy's talking about vacation ever. And
he went on one. He went on a vacation recently.
Yeah, but I wonder. Yeah, I like that. Jeremy, we could do this all day, man, and maybe we will. I think we'll have to bring you back for something in talking about the concept of non-op ACL rehab in the future. I think that's a very important from a sports rehab perspective. But tell us, I don't know if I even know this. You're a very thoughtful guy. You think about things very deeply. It's apparent. And you mentioned a lot of training and years and more than a decade of working with people. How did you even get here? What inspired you to go this route? You talked about the importance of just loving this profession. You're clearly one of those people. Why did you even pick PT?
Good question. I always loved, I guess, typical, a lot of the guys in physical therapy, males in physical therapy, always are interested in sports side. But so I just like to compete, anything, whether it's really like knockout or basketball or soccer. So I always had a love for sports. So that's how I got into that. It was actually a lucky Google search. Just put sports and medicine, and somehow, this is going back, now physical therapy pops up all the time, but it popped up, and I didn't know it existed. I'm not one of the more traditional PTs that suffered, I got an injury and then had to go through physical therapy to find out about it. I was lucky, and I shadowed the athletic training at my school physicians because I knew there was something in the medicine world. My mom liked to watch Diagnosis for Murder with Dick Clark. So I was always watching that. I was like, medicine seems awesome. So combine that with sports, it would be like the best thing in the whole wide world. Yeah, I got a great opportunity to shadow Jersey Physical Therapy and Mark Rubenstein, and just seeing how the interaction was happening. And I just thought it was a fun, enjoyable environment with clinical excellence seemed to be occurring there. And I know Mark, he definitely delivers that. I didn't really know what I was loving at that time was that bond that was created, and to see the progress over time, I thought was pretty special. It was it did push off that instant gratification when it was more delayed, and it caused more changes. I think more like life changes. And I didn't really know at the time if I was this fun. And again, it combined both of my like loves of medicine and sports, but it was really what sold me in was really the bond I could see Mark and his patients building. And that carried over into me. And the more people I was around, especially that really looked at human side of things and really psychological side of things, that really blending all that together really sealed the deal for me. This kind of the way that we do this in physical therapy is the perfect spot for me, where I can have the long talks and then I can flip the switch and yell at a kid in a motivational way to get yoked and squat heavy and perform manual therapy and do a technique or something of that nature and provide some relief for somebody else. So years. It just does that whole combination of things is pretty special. Which is probably why how I treat is kind of this multimodal sort of way.
Absolutely, man. It's a definitely. Go ahead.
So there's a non PG-13 version of what maybe seal the deal and go into PT, but I'll save that for off the air.
All right. We'll definitely have to hear that. But yeah, Jeremy, it's definitely inspirational. Your story, your love for learning, and how you incorporate just all the different learnings throughout your journey to be the practitioner that you are. And so totally understand why Altamash continues to speak very highly of you. And he fills me in sometimes on the things that he's learning through you. And so definitely appreciate you coming on here on educating me and our audience. And if they want to learn more about you, what are the social media that they should go to? What website should they go to find you?
Oh, great. So I need to be better about my own personal social medias, but I'm the decent doctor, which is the reason for decent is I'm always striving to be greater and better and everything like that. But I'm not saying I'm that way and trying to, I love this profession because it's a lifelong learning profession. That's where the decency comes from. But so that I'm the decent doctor on mostly Instagram is about most of what I utilize. My company's Trifecta Therapeutics, which I have the pleasure of leading, what I'd say is the strongest physical therapy clinicians, arguably in the nation. So you can see a lot from them and their different styles and flavors. Shout out to them. So that's at Trifecta Therapeutics. That's on all the major ones. If you guys have any specific questions, my email is jboyd@trifectatherapeutics.com, which is I know long, but feel free to reach out to me there or DM me. Always to help out, provide mentorship or asking.
Awesome. And no worries about the length. We'll put the hyperlink into the show notes. So that way people can just click on it and ask you some questions.
Yeah.
Jeremy, this has been a true pleasure. Hopefully we can get you on again, because I know there's some other topics we haven't discussed that I still have no idea what you guys are talking about with this ACL stuff. I'm in for a treat, I guess, if we're able to do a part 2. Yeah, Jeremy, thanks so much again. So ladies and gentlemen, Jeremy Boyd.
Thank you, Darsh. Thank you, Altamash. This was an awesome show. Keep doing what you guys are doing.
Thanks, man. Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes. Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at MedRedefined. We also want to thank our team for the production of this podcast, specifically Aretha Yepori on social media, Zainab Lugmani on research, and Sarah Khan for newsletter. If you enjoyed the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Now, time for the ever so important disclaimers. This podcast is intended for general public use and is for educational purposes only. It does not constitute the practice of medicine, nor should be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues.